Cardiopulmonary.com.
Okay, so today we're going to talk about something that's been a long time coming in terms of COVID-19. We're going to talk about the long-term effects of COVID-19. And now that we have some data and some information, potentially we can do something about it. And what this is here is simply a map of the human body showing in circles what are the most common symptoms of long-term effects of COVID-19, which we're going to define here. As you can see, it's fairly in-depth, fairly complicated. We're going to simplify it here, and we're going to go through it in a methodical way. So you may have known that there are a lot of terms that we use for persistent COVID-19 symptoms. You might have heard of long COVID or long haulers, post-acute sequelae of SARS-CoV-2 infection. That's abbreviated PASC, as you can see there. Post-acute COVID-19, chronic COVID-19, post-COVID syndrome is another one that we've seen. What's the definition? And the reason why we need a definition is because we need to standardize the research on this so that we can actually get research that we can compare. And so what's been suggested is that a definition for persistent COVID-19 symptoms is any symptoms that are 12 weeks or more after or during COVID-19 symptoms. So from the days that you've gotten COVID-19, if there are symptoms still persisting after 12 weeks that are not explained by another diagnosis, we're dealing with persistent COVID-19 symptoms. And what the research has been showing is that the length of these symptoms, how long these symptoms are in play, can certainly have a dependency on whether or not the patient had severe COVID-19, whether or not they were inpatient or outpatient, and can also depend on the type of symptoms. For instance, fevers typically go away pretty quickly, whereas shortness of breath, fatigue, these sorts of things, they can linger. So let's look at a couple of studies. This first study here on the left was published in the Journal of the American Medical Association, and it was about 300 healthcare workers in Sweden 60 days post their infection. And what they did here was very important. They compared SARS-CoV-2 positive patients versus SARS-CoV-2 negative patients because they wanted to have a control, a baseline. And when they looked at them 60 days post, they found that those that were SARS-CoV-2 positive, 26% of those had at least one symptom that was persistent versus just 9% in the SARS-CoV-2 negative. At 8 months, that number had gone down from 26% to 15%, but it was still lingering, and from 9% in the placebo down to just 3%. Now, 8 to 15% of patients versus just 4 in the placebo said that the symptoms that they had interfered with their work, social, or home life. These are significant. These are not just small little things that you might ask and they might happen to say. These are things that have meaningful impact. The second study was looking at 60-day outcomes among patients hospitalized with COVID-19. This was published in the Annals of Internal Medicine. A little bit of a bigger study here, about 1,600 subjects in the United States, again, 60 days post-discharge. 33% of them had persistent symptoms, and 19% had actually worsening symptoms. If you look at the prevalence of these, 24% had dyspnea or shortness of breath with stair climbing. 17% had shortness of breath or chest tightness. 15% cough. Interesting here, 13% had a loss of taste or smell. We're going to talk about that in this presentation, and actually some evidence that may tell us about practical things that we can actually do. So stay tuned for that towards the end of this talk. Interesting regarding this 13%, appears to be a smaller number than what actually may be the case, because if you look at people who have had a change in their taste or in their smell, it's a much larger number. But complete loss of taste or smell, yes, about 13% in this study. And so if you look at all the studies that have been done looking at the prevalence and the severity and the time period, and these are all the studies that were reviewed here, these references have been combined, and we're going to give a synopsis in terms of side effects and how long they might last. And so as you can see here, we've got mapped out on the x-axis the time period. We have 1, 2, and 3 months. And then we have the types of symptoms with the most common here at the top. So in these studies, anywhere from 15 to 87% had fatigue. And as you can see, these people very commonly had fatigue, and this happened to be the longest lasting symptom in general. 10 to 71% had dyspnea, which is shortness of breath. And you can see there that generally speaking, these things could last up to 2 months. Now, this is what they asked in the surveys. Remember again that it's 12 weeks or longer that would actually give you the inclusion criteria for long hauler syndrome or post-COVID that is long. So these are just showing you that these symptoms, generally speaking, can last a long time. Chest discomfort, about 12 to 44%. had that. Again, usually up to and including about 2 or more months is what can be expected. Cough, 17 to 34%, again, about the same period of time, about 2 months. And then notice that this taste or smell, again, no smell or taste as opposed to alteration. And so 10 to 13% had no smell or taste. I'm sure a much higher percentage had problems with taste or smell. And that, generally speaking, was found to last only about a month or so, but there are patients, clearly, that have had the symptom for much longer than that. And this is not unusual. There are other infections where people have lost their sense of taste or smell. It seems, however, to be a little bit more common in COVID-19. Now, that's not to say that there are less common physical symptoms that you could see, but the incidence here was less than 10% and with a much different variable time in terms of weeks to months. So joint pain, headache, Sicca syndrome, which is basically where you have dry eyes, dry mouth, rhinitis, perception of taste, again, poor appetite, dizziness, vertigo, myalgias, insomnia, alopecia, that's basically loss of hair, sweating, and diarrhea. All of these things have also been shown to last. In terms of common neurological symptoms, there's about 7 to 24 that had PTSD, that's post-traumatic stress disorder, where they have flashbacks. There's also 18 to 21% had impaired memory, 16% had poor concentration, and 23% had anxiety and depression. The vast majority of these last about 1 to 2 months, with some exceptions which last longer. And then there was this study that was done in Vancouver, Canada, which was a prospective study looking at patients that were discharged from a hospital with SARS-CoV-2. They contacted 101, 78 of them fulfilled the questionnaire. And what they found was some interesting data. 51% of these patients had a quality of life reduction because of these persistent symptoms. 50% had dyspnea or shortness of breath, 23% had cough. The drawback to this study was that there was no baseline to compare it to, but there it is nonetheless. And so as we are progressing, and hopefully in the United States and around the world, the incidence, the prevalence of acute SARS-CoV-2 infections are going down, we're now emerging into this post-COVID world where we are seeing patients with lingering symptoms showing up in the waiting room, waiting to be seen. And the question is what do we do with them? So from a physician standpoint, what should be the follow-up? What should we be doing with these patients that have gotten SARS-CoV-2? Well, the data and the recommendations seem to be if anybody is hospitalized with these symptoms of SARS-CoV-2, whether they be older or younger with comorbidities, that means other diagnoses, or without comorbidities, the consensus is that these patients should be followed up within a week to make sure that they are being followed in the outpatient world. Now, if they got their SARS-CoV-2 in the outpatient world to begin with and never needed to be hospitalized, then if they are older, like we're talking greater than 60 years of age, or they have comorbidities like kidney problems, congestive heart failure problems, diabetes, hypertension, then generally speaking, they should be followed up at about 3 weeks. And really, when you see them back, you want to get information about how that COVID-19 was treated. Did they get monoclonal antibodies? Did they get remdesivir? Remdesivir is thought to cause kidney problems. It's also limited in terms of kidney issues, and that's why we listed remdesivir there. Did they get steroids? That's really important to understand because you want to know whether or not they've been made immunocompromised or if they've been tapered appropriately off of those steroids, or whether or not they're still on those steroids. You want to know about the duration of illness and the types of interventions that they had. Were these patients on the ventilator? Did they have ARDS like we've talked about before? What's important to understand is that you do not have to recheck them for SARS-CoV-2 routinely to see whether or not they are negative. You may think you want to do that, but there's actually no evidence that that's beneficial in these type of situations. And then the next thing you want to do is ask them about symptoms. So you're going to be asking about shortness of breath. You're going to be asking about chest pain to find out whether or not they have symptoms. And a good way to break down those symptoms is, are they cardiopulmonary symptoms? Are there shortness of breath, chest pain, pain when inspiring, all of these things? Are they neurological? Are there issues of blood clotting, particularly in the extremities or even in the brain or in the lungs? What about problems with olfaction? And then finally, fatigue. And we're going to go through these step by step and look at the evidence to see what we can do in terms of these, and also throw in a little bit of personal experience that I have in my pulmonary clinic because I've actually seen patients with post-COVID-19, and I'll let you know what I've been seeing. So again, for cardiopulmonary, you want to ask about symptoms of shortness of breath. That's important. It could mean a lot of things. Shortness of breath could be a result of lung disease. It could be a result of heart disease. It could be a result of basically deconditioning. You want to know, is it happening at rest, on exertion, or when laying down? If it's when laying down, that is usually suggestive of congestive heart failure. And we have a video on our channel and also at medcram.com that talks about the different types of congestive heart failure. You'll also want to ask about cough. You'll notice that a lot of our patients had cough. Cough can be a symptom of other pathological diseases. It can also mean that the patient has something called cough variant asthma. This is where patients get a flare-up of their asthma when they have a recent viral illness, and they should be treated as such. The way to test that is by doing pulmonary function tests and things of that nature. We'll talk about that. Wheezing is another sign that you may be dealing with reactive airways disease, and they may need treatment for that. We have a video on asthma on our channel talking about how we manage asthma. Chest discomfort at rest or when breathing is usually related to a pleuritic pain. That means the covering of the lungs are inflamed, and when the lungs expand and contract, they rub up against the wall, and that causes irritation. That's a very common situation. You also want to ask about swelling in the lower legs or feet. That can be related to congestive heart failure. It could also be related to blood clots in the lung. And so these obviously are serious issues and should be evaluated by physicians. Palpitations, that's the term that we use for when it feels like there's a butterfly in your chest. This can often mean that there's arrhythmias going on. And again, that needs to be evaluated, especially in light of the fact that this SARS-CoV-2 can affect the cardiovascular system. Dizziness is a very nonspecific symptom. This could be related to the heart. It can be related to neurological issues in the brain. And so it's important to sort of ferret that out by asking them if they feel like they're going to pass out or if they feel like the room is spinning. If they feel like the room is spinning, that's usually more of a neurological issue, whereas if they feel like they're going to pass out or black out, that's usually a cardiovascular issue. These are the kind of questions that you want to ask if patients are coming in with cardiopulmonary symptoms. So the other thing that often gets asked is, well, they were in the hospital or sometimes even as an outpatient, and they got a chest x-ray, and the chest x-ray was abnormal. So you never want to leave an acute chest x-ray as being abnormal. You want to follow it through to make sure that that acute abnormality resolves. And if it doesn't, you want to follow it up to make sure that it's not a tumor or a mass. And in that case, that would be a reason to get a CT scan or some other advanced imaging. And so here we have on the left an example of what a chest x-ray looks like in a patient with COVID-19. As you can see, there are a lot of fluffy infiltrates in the lung. That usually means that there is fluid in the lungs, and that's not good. Fluid specifically in the lungs, and that's what's causing pneumonia. The problem is that the patients clinically, symptomatically, can get much, much better, but the chest x-ray is very delayed in getting better as well. And so we don't recommend repeating the chest x-ray for at least 12 weeks later. You'll notice that it's the same 12 weeks that we use to make the diagnosis of long-term COVID-19 symptoms. So 12 weeks later, what you should see is you should see resolution of those infiltrates and should see a normal chest x-ray. If you don't see a normal chest x-ray, then you need to be concerned about a persistent problem in the lungs. There could very well be another process going on. And so chest x-rays should be gotten at 12 weeks, but if things are getting worse, you might want to repeat those earlier to make sure you're catching those things. And then, of course, if you're concerned about tumors or masses or other things, then you may want to get more advanced imaging like a CAT scan to see what else is going on. But generally speaking, if you get the chest x-ray before 12 weeks, especially if nothing is going on with the patient and they're slowly getting better, you're going to see still an abnormal chest x-ray. So recommend getting it 12 weeks later, and then if it's normal, then you can check off that box and know that everything's good. The other thing that I often get on patients is something called an ECG or an EKG. And I will do this fairly easily without much of a bar to pass because it's a very cheap test to do. It doesn't take much time at all. You don't really need an appointment for it if you've got the machine in your office. And it gives you a lot of good information. And it's not risky at all. You just put a bunch of wires on the chest and you basically record the electrical conduction. In this case here, this patient had an ECG, and we can see something called ST segment elevation in a number of the leads all over this ECG. And this is suggestive of myocarditis or pericarditis, which is basically inflammation of the covering of the heart. Now, this is something that has been seen quite frequently, although be it not in the majority of patients with COVID-19. And so ECGs can be very beneficial, not only in looking at inflammation of the heart, but also at looking at other things. If the heart is enlarged, if the heart has had a decrease in its muscle tone, you would see reduced voltage. There's a number of things that you can glean from looking at an ECG. It's a pretty cheap test. And by the way, I would be remiss if I didn't tell you that we also have an ECG course on our website, medcram.com, that also gives you continuing medical education credits. It would help understanding EKG strategies and how to read EKGs. And I highly recommend going to our website and taking that course. Something that the experts recommend is getting an ECG on these patients post-COVID if there's any concern whatsoever with cardiopulmonary symptoms. A lot of times people ask about whether or not we should get an echocardiogram. This is an ultrasound of the heart. Now, I don't, and experts don't routinely recommend getting these. In other words, you don't get them for everybody that's had COVID-19. But there's a low threshold, in my opinion, to getting echocardiography. If there's any concern whatsoever, swelling in the legs, that's new. If there is a chest pain, especially if in the hospital the patient had a history of elevated cardiac enzymes, like troponins, this would be indicative that there was muscle injury on the heart. I would go ahead and get the echocardiogram to document if it wasn't already done in the hospital. If the patient has ongoing symptoms of shortness of breath and signs and symptoms of congestive heart failure, or as it's known now as just heart failure, that's when the heart is not able to pump very well or relax very well, then I would document that with echocardiography. It may give you a diagnosis. It may explain what it is that's going on. The other thing that echocardiography is very good at doing is also telling you what the pulmonary artery systolic pressure is. That is the pressure that the right ventricle or the right side of the heart is pushing against to get blood to the lungs. And that is sometimes suggestive of a pulmonary embolism. That's important because, as we found out last year in a New England Journal of Medicine publication that looked at autopsies in patients with COVID-19, they were 9 times more likely to have blood clots than patients without COVID-19. So again, echocardiography, I wouldn't get it routinely, but if there was any kind of signs or symptoms, that bar is pretty low for me to order that test. Let's talk about pulmonary function tests, because if patients, especially if patients are in the hospital and they were intubated and they had what we call acute respiratory distress syndrome, or ARDS, then there's going to be damage to the lungs, potentially even fibrosis. And one of the ways of measuring that is with something called a pulmonary function test. This is a test that measures how much air you can blow out and how fast you can blow it out. And it also measures volumes in these things that we look at here. There's also something called the flow volume loop. And by the way, we also have a course on our website at medcram.com looking at how to interpret pulmonary function tests. And so I think that's really important. One of the things that we also do in the pulmonary function test is something called a diffusion capacity. This is really important because diffusion capacity essentially is measuring the cross-sectional surface area of your lung, which is about the size of a tennis court. Now, if that is low in isolation, in other words, it's low but everything else looks good, that is suggestive that you may have blood clots in the lung. And so getting a diffusion capacity with your pulmonary function tests is always a good thing to do. The other thing that we can also do as a baseline, especially in patients with fatigue, is get something called a 6-minute walk test. So they walk as much as they can, as fast as they can, for about 6 minutes, and we measure how far they go. And based on that, we can get an assessment about what their functional capacity is. And it's something we can also track as we see them more frequently from those visits on, as we're managing and treating their long COVID symptoms. So the question is when do we refer to a specialist like a pulmonologist or a cardiologist if we've done these things and we haven't found the cause of some of the symptoms that have lingered for long term in these COVID-19 patients? That's exactly basically when you do it. You've looked for things, you've done an echocardiogram, you've done a pulmonary function test, you've done an ECG, you've done these things, and nothing is really coming out into the open there in terms of a diagnosis. Then you can refer to the specialist, and since you've done all of this advanced testing, there's going to be a plethora of information that the specialist is going to be able to review, look at, and make a determination about where to go next. Now, I'll tell you that I've had patients referred to me as a pulmonologist that have had long COVID symptoms that have been going on and on and on. One of the first things that I often order is something called a D-dimer test. A D-dimer is a product of coagulation in the body, and it's a very sensitive test. And so because it's a very sensitive test, if it's negative, it's very helpful at telling me that there's no chance that this patient has blood clot issues as an outpatient. But if it's positive, there are so many things that can make this test positive that I can't really tell you for sure that it's related to blood clots. And so at that point, what I would do is get further testing with a bilateral lower extremity ultrasound Doppler of the lower extremities to look for blood clots to make sure that that's not the case. And instead of getting a CT scan with contrast, which is often what people do when they're looking for blood clots in the lungs, unfortunately, those CT scans are not very sensitive for chronic clots. They're very good for acute clots. But instead, what I do is I get something called a VQ scan, which is much better at looking for chronic clots. They also need to get a chest x-ray the same day so the radiologist can compare the VQ scan with the chest x-ray. Now, just be aware that if there's a lot of infiltrative changes on the chest x-ray, the VQ scan may not be a good test to use. You may have to use the CT scan, but just be aware that CT scans are much better at looking at large central acute clots, and VQ scans are much better at looking at distal, peripheral, and chronic clots. The other test that I often do is a methicillin challenge test, and this is in a patient who would, let's say, have a normal pulmonary function test, normal breathing, they're able to breathe out okay and breathe in okay, they don't have symptoms of asthma, but maybe it just comes and goes. So the day that they came in for their test, they were feeling fine, but let's say 2 days later, they're not doing so well. What a methicillin challenge test will do is it will provoke the lungs to see if they're sensitive to that type of thing. And we will see that there in the clinic, in the pulmonary function lab. And that might be a diagnosis of what we talked about before, which was cough variant asthma, in which case the treatment would be inhaled corticosteroids. We have a whole course on interpretation of these pulmonary function tests over at medcram.com if you're interested. The other thing I would often get is a complete metabolic panel. Oftentimes, SARS-CoV-2 causes issues with the creatinine, which is what we measure when we're concerned about kidney function. The BUN is also something that we look at as well. If you want more information about how to read creatinine and BUN on these complete metabolic panels, I encourage you to look at our acute renal failure, also known as acute kidney injury lecture series at medcram.com. It's free. And there's also an acid-base lecture as well. And that's what the CO2 is. The CO2 on the basic metabolic panel is actually looking at bicarbonate. And bicarbonate is a base. Sometimes that can be effective adversely when a patient is infected for a long period of time and can cause acidosis. So these are the personal experiences that I've had taking care of patients. I've had a number of post-COVID patients in my clinic, and in a considerable amount of them, just by looking for clots using a D-dimer, I have found them and have treated them. And these patients are hopefully on their way to recovery. Time will tell. Okay, let's talk about the neurological implications here. So when these patients come in complaining of neurological issues, we do a complete neurological history and examination. I would only, and the experts recommend only imaging if there are focal deficits. For instance, a particular side of their face is droopy, or a particular one of their eyes won't close very well, or if their tongue deviates to one particular side. These are what we call focal neurological deficits. If you see that, I would definitely recommend getting urgent neuroimaging like a CAT scan of the head. This here is a CAT scan on the left. This over here can actually look a little bit deeper into the brainstem and the lower portions of the brain down in this area, and that's called an MRI. That is often also something that is useful, especially if the focal neurological deficits are coming from that part of the brain, and a neurologist or a good internist will be able to tell that. If there is not focal neurological deficits and the patient just has this generalized slowing, there is something called neurocognitive testing that you can get more information about that will test to see if the patient is able to think well, and also to quantify it so that you can get tests later to see whether or not it's getting better or see if it's getting worse. Okay, let's talk about blood clotting itself. We kind of alluded to this. Again, careful physical examination with attention to extremities for ischemic changes or swelling. Now, ischemic changes would be if it was pale or white. Sometimes even blue would tell you. So if there's color changes, that is a sign that something may not be right. Also, if you're normally able to feel pulses in your wrist, generally speaking, and if you don't feel those, that can also be a problem. Swelling is also an issue. So ischemia would be a problem with the artery. Swelling could be a problem with the vein. You could have issues with swelling in the veins that is causing swelling in the hands. So blood clots in the vein could cause swelling in the hands. And so if you see any of that in any of the extremities, the recommendation would be to get an ultrasound to see whether or not there are clots. If patients are taking anticoagulants, and I see this quite often, patients leave the hospital and they've been put on anticoagulation in the hospital. The question is how long should they be on that anticoagulation? Well, generally speaking, that has to be determined by the physician. It can sometimes be very complicated because they may have other conditions that may need to keep them on anticoagulation. So I can't answer that question remotely from here. But generally speaking, if a clot is provoked, in other words, if something caused it to happen, like the patient was on a medication, or the patient had a cancer, or the patient was on a long flight, all of these things would mean 3 months and then stopping the medication so long as you could remove the provoking factor. If it was unprovoked, in other words, you don't know what caused it, it just happened on its own, it could be indefinite time of anticoagulation. So all of these things are things that you must take into consideration. Here we have a picture here of an ultrasound of clots in the veins. Okay, let's go on to olfaction. And this has been something that's very unique about COVID-19, something that we'll get into here. What it's known as is something called post-infectious smell loss, or PISL. This has been seen in COVID-19 patients. It's one of the things that are very specific for COVID-19 that we don't see a lot of in other post-viral syndromes, but it can be seen. And surprisingly, this has been looked at in the past. So as we said at the beginning, common physical symptoms, we said that about 10 to 13% of patients that were infected had no smell or taste. Well, this number goes up significantly if you include in there abnormal taste or abnormal smell or things that don't smell exactly the way they should. And so this is actually, as it turns out, a very common problem. And if you look at the nose, where the olfactory nerves are, you'll see it's a very complicated system. This is what it looks like histologically with the little receptors for the cells here. What they found out, which is very interesting, is that the cell receptors for these are attached to neurons, and the neurons have no ACE receptors, or I should say ACE2 receptors. And so the question had been for a long time, is it the neurons of the olfactory system, cranial nerve number 1, in other words, that is becoming inflamed because the virus is infecting it? And the answer turns out to be no. It is the cells of this supporting tissue here that is around the nerves, around the cell bodies, that has the ACE2 receptor, and it's that is getting inflamed, they believe. And that is what's causing the loss of smell. So that's good news because we're not destroying the actual neurons, which may not grow back. And here's an interesting study that was done on mice titled Non-Neuronal Expression of SARS-CoV-2 Entry Genes in the Olfactory System Suggests Mechanisms Underlying COVID-19 Associated Anosmia. Anosmia means inability to smell. And you can see this was published in July of 2020 in Science Advances. And what they said here is, quote, single-cell sequencing revealed that ACE2 is expressed in support cells. That's what I was showing you before. Stem cells and perivascular cells, rather than in the neurons themselves. Immunostaining confirmed these results and revealed pervasive expression of ACE2 protein in dorsally located olfactory epithelial substanticular cells. Those are the cells that I was showing you before. And olfactory bulb pericytes in the mouse. These findings suggest that COVID-2 infection of non-neuronal cell types leads to anosmia and related disturbances in odor perception in COVID-19 patients. And that's exactly what we see here. So we've got the olfactory bulb, which is part of the first cranial nerve. That is the main nerve there in the brain that senses smell. We have the bone here, which is the cribriform plate, and you can see that these very sensitive extensions of the nerve go through these holes in the cribriform plate. And we go here into the olfactory neuron, which are pink. But it's these supporting cells that are gray here that have the ability to be infected with the SARS-CoV-2 virus. And when they swell, you can see that it's going to offer problems with the olfaction in the nose. So regarding loss of smell taste, which is PISL, generally speaking, this usually gets better on its own. But that is no comfort for those people listening to this that still don't have normal taste and smell. Generally speaking, it rarely lasts for more than a month. But if it does, if you have a patient, if you're seeing somebody or know somebody where this has lasted for a long period of time after COVID-19, they may seek an ear, nose, and throat specialist for something called olfactory training. So what is olfactory training? And is it something that you can do on your own? So let's review the data and let's take a look and see exactly what olfactory training is. So this has actually been in the news. Olfactory training in COVID-19 for related loss of smell. what you can see is this person is sniffing something called essential oils. And the question is just, why are they doing that? And what is the research? What is the data that supports this type of behavior? And I want to turn your attention over to a really great article that reviewed this in 2020 in the Laryngoscope titled, "Is Olfactory Training Effective Treatment for Post-Infectious Smell Lost?" And if you want to know more about this, I would highly recommend looking up this article, which we'll put a link to below. So before we get into that, we have to talk about some definitions and some preliminaries. There's something called a sniff and sticks test, and this is kind of interesting, so just bear with me. Sniff and sticks are basically markers that were marketed in Europe, and they have different scents and smells that you can smell from these markers, and you can see what they look like here. They have different colors, and this is basically what was used in the research to assess objectively someone's ability to correctly smell odors the way that they're supposed to smell. So as you can see, the sniffing sticks, which are produced in Germany, comprises of 3 subtests resulting in 4 scores. So it's known as the TDI score, and the T is the threshold score. In other words, how well can you sense something that smells? Then there is a discrimination score. How well can you discriminate one from the other? And then how well can you identify what is the correct odor? So that's known as a TDI score. And the higher the number, the better the subject was performing. And then they can add all of those up, and they get something called a TDI global olfactory score. So that's the addition of all of those. And generally speaking, you don't have to know these numbers, but if it's less than 16.5, that means you don't have any smellability at all. If it's between 16.5 and 30.5, it's hyposmia, and that is where you're not smelling well. And then if it's greater than 30.5, then actually you're smelling quite well. That's hyperosmia. But the key that I want you to understand from this is that if there is a change of equal to or more than 6 points, that is a significant number, because as it has been shown, that is the number that is perceived by at least 60% of subjects to represent a real improvement in olfaction. So that is the number that we're going to use to see whether or not things improve or don't improve. And so that's where we get the 6 points. Let's take a look at some of the data. So this was a paper that was published back in 2009. It was a prospective controlled study. It was using 35 patients, all of which had lost their ability to smell. And they randomized them into 24 interventional patients and 11 placebo. And what was the intervention? The intervention was that there was a 10-second exposure to smelling the essential oils of rose, eucalyptus, clove, and lemon twice daily for 3 months. And the endpoint was, again, the IDT score of greater than 6 points. So when they looked at this, they found that in the intervention group, 21% of those patients were able to have a TDI improvement of at least 6 points versus only 6 in the placebo group. And this was statistically significant. And it kind of was the landmark original study that put olfactory training on the map. But there was another study that was published. This one was in 2013, titled "Olfactory Training is Helpful in Post-Infectious Olfactory Loss, a randomized controlled multi-center study." And what they did here was they took 144 subjects with PISL, and they did a very elegant study. In the intervention group, they had very strong undiluted oils of, again, the same essential oils: rose, eucalyptus, clove, and lemon. And what they did was for 15 seconds, twice each sitting, twice a day. So for 15 seconds, they would sniff rose, and then they would go to eucalyptus for 15 seconds, then they would go to clove for 15 seconds, and then lemon for 15 seconds. And then they would go back and do it again, rose, eucalyptus, clove, and lemon, knowing exactly what they were smelling and trying to imagine and think about the thing that they were smelling. They did it twice a day, and they did it for 4 months' time. Now, over on the placebo side, they took the same oils, but they significantly diluted the oils down so that only 10% of a healthy person could actually detect the smell of that oil. So this was kind of their sham or placebo intervention. And again, they used the same oils: rose, eucalyptus, clove, and lemon. Again, 15 seconds, twice each sitting, twice a day for 4 months. And they had 70 in the intervention group and 74 in the placebo. What they found at the end of 4 months was that in the placebo group, where there was only 15% that had reached a TDI of greater than 6 points, In the intervention group, there was 26%, so 11 percentage points higher than 15 that had a TDI of equal to or greater than 6 points, which was a significant issue. Then what they did was they did a crossover design. So now these people got to do this side and these people got to do this side. Why this is important, by the way, is that if there were any confounders or any other issues with this, this would have been elucidated. It also increases the power of the study tremendously. So not only do you have a placebo here that's very, very close to the intervention, but you also have a crossover trial. So that makes it very, very important. Here, however, 16% got better on this side, 20% got better on this side. So what can we take from this? We can take that, number one, the intervention worked. Number two, because this was statistically significant. Number two, that the intervention seems to work better if it's done earlier. Because notice here, this was 26% and this was only 20%. In fact, when they looked at this, those that had symptoms for less than 12 months, 63% of them were responders, whereas if it was more than 12 months, it was only 19%. Now, in terms of side effects from doing this, they found that there was an 8% minor side effect rate, and that was including epistaxis, which is nose bleeding, a little bit of nasal burning, and also some hay fever. So again, this is a really elegant study that showed pretty conclusively that the intervention of olfactory training can be effective at helping people regain their sense of smell and taste. But we're not done yet. There was another paper that was published in 2015 titled Modified Olfactory Training in Patients with Post-Infectious Olfactory Loss. And what they did here is, again, they took patients with PISL, about 85, and instead of randomizing this time, they did age and gender match control. So all of these people had PISL. And what they did in the classic sense here is they did exactly what they did before in the other one. So they used rose, eucalyptus, clove, and lemon. And for the modified group, they used the same essential oils as before, but they changed it up later with 2 groups of 4 new essential oils, as you can see here further in the trial. And then finally, in the control group, they did nothing to these patients. So what they did after about 3 months is they continued to do in the 3 months the same type of rose, eucalyptus, clove, and lemon. But in the modified, they stopped doing the rose, eucalyptus, clove, and lemon and switched it up to menthol, thyme, tangerine, and jasmine. They did that for another 3 months. And then they switched it out again to bergamot, rosemary, gardenia, that should be an A, and green tea. And what they showed was something that was really interesting. They found that whereas nobody in the control group had an improvement that was beyond 6 points, 56% of those with PISL in the modified group, where they switched up the essential oils, had a TDI improvement of 6 points, and 46% in the ones that just had these 4 for the entire length of time had an improvement of greater than 6 points. So what does that tell you? It tells you that the more essential oils you can do over time in a reasonable manner, the higher the improvement may be. And the difference between these two was a p-value of 0.034, which was statistically significant. And this, of course, versus the other two, had a p-value of less than 0.05. So what does this tell you? It tells you that olfactory training is beneficial compared to control, and that if you do a modified type of thing where you're doing 4 for 3 months, a different 4 for 3 months, and then another 4 for 2 more months, might actually give you a better result. Finally, in 2016, this randomized controlled trial titled Long-Term Effects of Olfactory Training in Patients with Post-Infectious Olfactory Loss was published, and this is what they did in that study. Again, 111 patients with PISL. The intervention was rose, eucalyptus, clove, and lemon. This time, however, they did it for 10 seconds on, and they gave it 10 seconds off, so they didn't smell anything for 10 seconds. And they did this for 5 minutes on each of these, rose, eucalyptus, clove, and lemon, twice a day, and they did it for 4 months. And again, the no training they didn't do at all, and they did this for 4 months in both of these intervention arms. But in this middle intervention arm, they stopped and they didn't do it anymore. Whereas in this arm, they continued doing it for another 9 months for a total of 13 months. And what they found at the end of those 13 months is that there was a trend to a higher success rate in terms of a TDI of greater than or equal to 6 points compared to 58% of a TDI of greater than or equal to 6 points. Now, I say trend because it was not statistically significant, but they may not have powered the study adequately to detect that statistical significance. This, of course, was statistically significant in terms of it was greater than 37%. And so there's the possibility that the use of these essential oils can help speed up the restoration of the sense of smell and taste. Now, this has also been seen anecdotally. I have had a number of patients tell me that they've been able to get their sense of smell back from the use of essential oils. And here we've got some of the protocols here that are used in these randomized controlled trials. And so I think it would be worthwhile having a discussion with your physician to see whether or not olfactory training with essential oils is appropriate for you. Let's real briefly follow up with fatigue. So fatigue is a difficult thing to assess. There is a difference between fatigue and sleepiness. With fatigue, you are awake, you just have low energy. And there's a number of various tools that you can use, as we see here. You can look these up on the internet and use these. I find that this would be helpful if someone has chronic fatigue. And of course, there's a lot of data on how to treat chronic fatigue syndrome. And being able to assess it and see whether or not it is improving, I think, is good. I think right off the bat, making sure your patients are getting adequate rest and having good sleep hygiene. Even though we don't know whether or not fatigue from COVID-19 is similar to chronic fatigue syndrome, there are a number of treatments that are being used for chronic fatigue syndrome that might be applicable in fatigue from COVID-19. Things like an exercise program and cardiopulmonary exercise training or cardiopulmonary exercise rehabilitation. More research is needed at this time. We have a number of courses on medcram.com that look at insomnia and obstructive sleep apnea, and I think that would be important. Also, there are some tips here in terms of what to do if you have chronic fatigue or fatigue issues in your life. Another potential treatment that's been looked at and suggested for long COVID symptoms is simply vaccination. And there is this paper that was published on May 25th in the Annals of Internal Medicine titled Symptoms After COVID-19 Vaccination in Patients with Persistent Symptoms After Acute Infection, a Case Series. So in this study, there were patients that were hospitalized in the UK, and they identified about 163 subjects. And they were followed after discharge from the hospital at 8 months. Now, from those 163 patients, 78 of them followed up. And of those, only 44 received a vaccine. Now, what they had done up until that point is every 12 weeks, they had a number of questionnaires. And then at whatever point along this line they got a vaccine, they were followed up 1 month later. And this was done blindly so that the people asking the questions on the questionnaire did not know if the patients had been vaccinated or not. So 163 people were hospitalized and discharged. Of those, only about 78 of them followed up, of which 44 of them got the vaccine. The question is did the vaccine seem to help the symptoms post-hospitalization after they got the vaccine? So there was no control group in this study. And here you can see a lot of the different types of symptoms that the patients reported on the questionnaire. You can also see which ones had improvement or resolution after they got the vaccine in the dark green. And in the light green, these things were unchanged. And those that were in the light pink were those things that actually worsened. So actually, of the 159 symptoms that were described before vaccination, 71% stayed the same. 6% got worse, and 25% got better. When they did the analysis between the two types of vaccines that were available at the time, the Pfizer-BioNTech and the Oxford-AstraZeneca vaccine, there was no statistical significant difference between those two vaccines in terms of the outcomes that occurred. So this is interesting data, but by no means definitive, as there is no control group here. What it does seem to suggest, however, is that having symptoms worsen from COVID-19 seems to be pretty rare after vaccination. So as you can see, this is not an easy topic. It's very complicated. There are many aspects to this because SARS-CoV-2 affects many aspects of the human body. But I think this is a good starting off point, and I think as more data comes back from the studies that are currently underway, we'll have a better understanding of how to treat patients with COVID-19 that have symptoms that have lasted for more than 12 weeks. Thanks for joining us.